ونبدأ أول presentation, Pediatrician and Neurosurgeon Hardship by Professor Sahar Hassanin, Professor of Pediatric and Neuropediatric. بس اتفضلي يا دكتور سحر.
Okay. We'll start with the daily problem of hydrocephalus. This is a scene. All are neurosurgeons. I'm the only pediatrician or neuropediatrician among them. Okay. What is the daily problem we face? We have neonatologists here. We have fever hospital specialists, and we have pediatricians. We have different specialties, and of course, pediatric neurology. We have to highlight the importance of anticipation and early diagnosis of hydrocephalus, and to find out a solution for prevention. Prevention is much more better. We all know about the hydrocephalus. It is increase in CSF volume inside the ventricular system, which will lead to, might be associated with malformations or neural tube defects. And the gold standard, or what was used to be a gold standard of management, the ventricular peritoneal shunt or tubing, the presentation is variable, could be non-specific at all. And I think we have different presentation. Drowsiness and disabled conscious is emergency, and you have to perform neuroimaging, Dr. Khaled, in any child with disabled conscious. Please, emergency. Headache, vomiting, irritability, high-pitched cry can occur due to any disease. In the neonatology, we have the sepsis, neonatal sepsis, can present the same presentation. Is it okay? The classic presentation in infants, progressive enlargement of the head circumference, and tense bulging anterior fontanelle. In the NICU, you have these cases. Sunsetting appearance and dilated veins. This is a clinical or classic. We don't want to reach this stage. This is historical now. The presence of, in older children, the papilledema, the sixth nerve palsy, the vomiting, and increased intracranial tension. Presence of seizure, it is non-specific presentation. Presence of tachycardia, bradycardia, mottled skin. Again, it will complicate the picture. And sometimes the neurosurgeon send us the child with a shunt and to treat sepsis. And he is actually a shunt problem. The burden of hydrocephalus and DB shunts. Pediatric hydrocephalus is one of the most common neurosurgical treatable cause of disease. Factors lead to delayed presentation to medical care depends on the, in Africa differs from other countries. The etiology differs according to the country. We have intraventricular hemorrhage and prematurity, congenital causes in the developed countries, and the post-infectious hydrocephalus in the developing countries, which we are situated in Africa. So we are going to talk about the hardship in hydrocephalus diagnosis and management. We have a patient who will be treated acutely, surgically, and at the same time, he will need a longitudinal management, a lifelong shunt-dependent life. To complicate the problem, in both infectious cases, we might have the encysted hydrocephalus, which is difficult to treat because one of these cysts will press on the other, even in the presence of the shunt. The shunt complications are well known for all. Professor Asim Munir is our neurosurgeon, and he started a registry for hydrocephalus in Egypt, I think 10 years ago. And this, I took this result from him. The post-infective causes, we have 23% of the registry, and 29% the Arnold-Chiari malformation. We have a very large number presenting to the maternity hospital to deliver with malformations. We have daily 2 or 3 cases with meningomyelocele. Is it okay, Dr. Hassan? Daily, on daily basis, we refer cases with hydrocephalus, meningomyelocele, and Chiari, and we don't have the capacity to treat them. 12% congenital aqueductal stenosis, 12% post-hemorrhagic hydrocephalus. Again, the source is the NICU with intraventricular hemorrhage due to prematurity. The tumor-related is just 8% of the cases. It's very low in contrary to the other reported numbers. Now, if I have a 45 days NICU graduate, he spent 30 days of his life inside the NICU, and the mother came to me because of the progressive. She noticed that his head is enlarging, and it should be noted by the NICU during graduation from the NICU that he should follow his occipitofrontal circumference weekly at least. And this is his CT scan. And I'll let Dr. Hassan to tell us how we are going to manage this case. Before we can a VB shunt be considered the gold standard to treat pediatric hydrocephalus? Dr. Hassan, you will answer this question. We have a good communication with the neurosurgery and the pediatric, the imaging department and the fever hospital. We need to hear the different perspectives. Hagar will present another case, and then we will continue after that. Okay.
إن شاء الله نكمل مع الدكتورة سحر. I have the pleasure to introduce Dr. Hagar. She will talk about the common presentation of the rare disease.
I am going to present a common presentation of a rare disease. A 4-year-old male patient who was developmentally normal till 2021, patient developed persistent vomiting. He received medications without improvement. 3 months later, patient did CT brain, which showed hydrocephalus, and VB shunt was inserted. And this is the CT brain before shunt insertion. In 6/2021, shunt was inserted, and this is CT brain after shunt insertion. In 6/2022, patient developed multiple attacks of seizures. Some was febrile and some was afebrile. 6 months later, in 1/2023, patient developed uncontrolled seizures. Upon them, he was admitted in BQ and shunt was removed. In BQ, CSF was withdrawn. It showed high proteins, viral, bacterial, fungal panel were negative. IVIG and solimidrol were given. Shunt was removed and the patient regained his baseline consciousness. 1 week later, patient readmitted in BQ in status epilepticus, intubated, convulsions were controlled, but he didn't regain his baseline consciousness. Patient wasn't recognized her mother, not interactive, and lost her own motor function and cognitive function as well. CSF was measured several times and it was normal, and all parameters were normal except for high proteins, and they were double the upper limit. The most striking thing in MRI brain is present cystic-like nodular lesions, nodular thickening, and it was detected as source of infection that may be cystosarcosis. So extensive infection workup was done, including cultures for mycobacterium, fungal, and viral cultures, and they were all negative. We prepared a meeting with the radiology staff team, and Professor Dr. Shaima Abdesattar asked to do MRI spine. This is MRI brain. It showed cystic-like nodular lesions, extra-axial, in subarachnoid space and basal cistern. And this is MRI brain and whole spine. This is MRI spine. When we do it, we found this cystic-like nodular thickening in spinal cord also. MRI spine show extensive involvement of leptomeninges in spinal cord. We consulted neurosurgery and open biopsy and tapping CSF was done. CSF pressure this time was high, 25, and so BB shunt was inserted again after 1 week of biopsy taken, and patient started to regain his baseline consciousness and motor and cognitive function. And this is a surprise. Pathology of dorsal spine cord and meningeal biopsy are keeping with diffuse leptomeningeal neuronal tumor. This is diagnosis going with diffuse leptomeningeal neuronal tumor. What is the differential diagnosis of this tumor? Post-viral hydrocephalus, TB, meningitis, parasitic infection, cystosarcosis, brain abscess, brain metastasis, chemical meningitis, cord compression, sarcoidosis, and steroid myopathy. Patient started chemotherapy, started vincristine as induction therapy in 2023, and this is protocol of management. When we following up the patient, his motor and cognitive function are improved dramatically, and the patient could sit and could recognize his mother again. This is very long history and very interesting case. When we looking for in the literature, we found that the clinical course for the majority of patients with diffuse leptomeningeal neuronal tumor is indolent, with some patients displaying slow asymptomatic progression without therapy for over 18 months. Unfortunately, for subset of patients, the clinical course is more aggressive and results in patient dying from this disease. Treatment strategies employed for patients with this disease range from observation only to chemotherapy to craniospinal radiation. Thank you.
شكرا جزيلا للدكتورة هاجر. We'll move to the next speaker. الدكتورة مروة محمد, Assistant Lecturer of Radiology. Her presentation about imaging of hydrocephalus practical approach.
We will talk about imaging hydrocephalus practical approach. Pediatric hydrocephalus is the most common correctable neurological problem in infants, children, and adolescents. First of all, ultrasound is very important modality for diagnosis of hydrocephalus. It is in the neonatal period where fontanelle is still open. Ultrasound using high-frequency sound waves is non-invasive, widely available, radiation-free, and we can use Doppler for detection of both ACA and MCA. Again, transcranial ultrasound is the primary imaging modality in the assessment of neonatal and infant brain. The technique is readily applied at bedside, doesn't involve ionizing radiation, cost-effective, and can be used sequentially. So, what is the role of ultrasound in assessment of ventricular system? First, detection and grading of hydrocephalus. And the most important thing is document and grade post-hemorrhagic hydrocephalus in preterm neonates. We all know that ultrasound is used as a sensitive tool for screening of hydrocephalus in neonates in NICU. Then CT. We have to know that according to ALARA, we have to preserve the CT for emergent situation only, when clinical benefits should outweigh the small absolute risks. Radiation doses from CT scans have to be low as possible as enough. And whenever alternative procedures is available, we have to preserve the use of CT, as using of ionizing radiation is very dangerous for the infant and pediatrics. Paper said that estimated increased risk of cancer over a person's lifetime from single CT scan increased from 0.03 to 0.05%. So when to use CT? We use it when time restrictions prohibit a delay in imaging as unstable, unresponsive patient. Anesthesia restrictions limit access to MRI. And finally, unavailability of MRI or ultrasound. In CT, we see the dilatation of the ventricular system, together with the transependymal CSF permeation that indicates presence of acute hydrocephalus. MRI. Advantage of MRI that no ionizing radiation and high resolution with multiplanar imaging capabilities, and using of MRI contrast by gadolinium had no adverse reactions, include allergy and no nephropathic. Disadvantage that need more patient cooperation, so need sedation for patients below 7 years. Longer duration of scanning, the patients are isolated and so not suitable for unstable patients in NICU, not suitable for most of medical and life support devices, and finally, it's expensive. First of all, we have to know the anatomy of the ventricular system. The CSF production is from the choroid plexus, and so through the lateral ventricles, foramen of Monro, third ventricle, and to the aqueduct of Sylvius, to the fourth ventricle, and so both foramina of Luschka and foramen of Magenti to the spinal canal, and then drainage through arachnoid granulation to the different sinuses. What are the different protocols of MRI for diagnosis of hydrocephalus? First of all, the conventional images using T2 axial and the coronal image. MRI T2 detection of the ventricular system as a slit-like ventricular system, together with the normal white matter around. The coronal image is important for diagnosing the distance between the frontal horns and the temporal lobe, and again, they use to detect the both hippocampus. Then axial flare, and we all know that flare is important for diagnosis of different white matter abnormalities around the periventricular area. Again, the conventional image using sagittal T2, and it's important for detection of CSF flow as a signal void in the prepontine and the aqueduct of Sylvius, as we see here. It's important to know that using of not conventional only images T2 and using of 3D heavily T2, or we call it T2 drive, it's very important as it eliminates the artifacts. As we see here, the perfect anatomy with detection of it. Of the third ventricle, we see here the third ventricle. And third ventricle has anterior and posterior recesses. The anterior recesses include the chiasmal recess and the infundibular recess and the posterior pineal recess, together the lamina terminalis and the membrane of Lilliquist. What is the advantages of using 3D acquisition? Bright fluid signal intensity, high spatial resolution, useful for evaluation of the sternal portion. Again, using of T2 conventional image and T2 drive, and the fast field echo. The fast field echo has the advantage that no any artifacts present here, so perfect visualization of the CSF. The last one is phase contrast, and phase contrast is using image for detection of CSF flow, as we see here in the phase image. CSF appears in systole and diastole, and systole is appear white and diastole appear black. This is in systole, and this is in diastole. Again, we can use axial images from the phase contrast and draw a ray in the aqueduct of Sylvius appear as white, and from it we can draw a curve for detection of different velocities of CSF. So what's the value of CSF studies? First of all, diagnosis of hydrocephalus. We know it by enlargement of anterior and posterior recesses of the third ventricle with downward convexity of the floor of the third ventricle, as we see here. This is the anterior recess, and this is the floor of the third ventricle. We have to know that in the ex vacuo dilatation or brain atrophy, secondary ventricular ex vacuo dilatation, here the recesses are normal, unlike here with the anterior recesses are widened. We can see the dilated temporal horns, detection of hydrocephalus. Narrowing of the ventricular angle and widening of the ventricular horn radius are complementary for diagnosis. And using, again, Evans index also. So we have to know what if it's hydrocephalus or atrophy. And again, by seeing here, the anterior recesses are normal. So it's ex vacuo dilatation secondary to brain atrophy, while there, it's true hydrocephalus where the anterior recesses and posterior recesses are widened. Second, determine the type of hydrocephalus, whether it's communicating or non-communicating. As we see here, the flow void in the T2 images and perfect detection in T2 drive, there's CSF alongside its communicating hydrocephalus. We have to know that a beat fall is depending upon the T2 only for detection, conventional T2 only. Here, this is signal void, so we can see that's communicating hydrocephalus. But by doing T2 drive, we see here a membrane distal to the site of signal void. So again, T2 drive and the fast field echo, it's very important as a modality for diagnosis of hydrocephalus. Third one, it demonstrates the site of obstruction in non-communicating hydrocephalus. And again, we see here, it's hydrocephalus, and by using the high resolution 3D, we detect in the foramen of Monroe, there are different adhesions. Again, it's hydrocephalus with there's adhesion in the supraaqueduct of Sylvius, and here in phase contrast, no flow is detected through aqueduct of Sylvius. These different membranes are seen in the aqueduct levels. And again, we have to use the T2, the 3D drive is very important as high resolution. Again, this is a membrane, and in the phase contrast, no flow is detected here. Preoperative assessment, prior third ventriculostomy, and it's very important. We use T2 image conventional, and again 3D image for detection of the prepontine CSF. And here in conventional T2, the signal void in the prepontine system. And it's important that in 3D, the membrane of Lillquist is important to document it. It's a variant in many infants. We see here that the 3D high resolution see that membrane adhesions here in the foramen of Monroe. Post-operative assessment of ventriculostomy. We see that the flow void presence in the 2D image. Here, this is conventional T2 and the signal void. So again, we have to look at 3D drive image. Why? Because here we see these signal voids and we see it's normal and functioning ventriculostomy. While when doing the 3D image, here there was a membrane. And after 3 months follow-up using 2D conventional image, really this was a membrane and not functioning third ventriculostomy. Post-operative assessment for presence of different membranes. On phase contrast, no flow here in the third ventriculostomy. It's a normal, excellent functioning ventriculostomy, and this non-functioning ventriculostomy using phased contrast images. Last one is VP shunt assessment. Assessment of VP shunt in the coronal 2D image appear shunt as the blackish circle. And again, using phase contrast is the whitish mean functioning shunt. Again, the drive, T2 drive images is excellent for detection of the whole shunt and its lumen and detection if there is any membrane or adhesions. Here, shunt. This shunt malfunction in the form of cystic dilatation around this, the shunt itself. And the shunt reservoir with collection around. In this 2D image, conventional image, alone we can detect the shunt, it's good or not. But again, using the T2 drive, a 3D T2 drive, we see here the shunt with membranes around, so it's not functioning shunt. Again, it's membrane around. So take home message. Transcranial ultrasound is a good tool in the neonatal period in diagnosis of hydrocephalus and post-hemorrhagic sequelae. CT is only used in emergency situations or while no other modalities are available. Sagittal 3D sequences is crucial for assessment of the anatomy of TSA pathway. 2D phase contrast in mid-sagittal section is important for functional assessment, detection of flow and velocities. MRI is important to determine if the hydrocephalus is communicating or not and to detect the site of obstruction. MRI is valuable in preoperative and postoperative assessment of third ventriculostomy, as well as detection of shunt malfunction. Different papers for further information. Thank you.
شكرا جزيلا دكتورة مروة على هذه المحاضرة القيمة. أولا أنا بنتهز الفرصة أن أنا أهني أساتذتي الأفاضل في وحدة الأعصاب كلية الطب جامعة عين شمس على هذا النجاح الباهر لهذا المؤتمر المتميز دوما، وكل سنة ما شاء الله بيزداد تألقا وإبهارا وتميزا كما تعودنا. هي الوحدة العظيمة التي كلنا تعلمنا فيها ونشأنا فيها وترعرعنا فيها وما زلنا نتعلم منها الكثير والكثير. حفظ الله أساتذتها على مدى الدهر وزادهم علما وتوهجا وإبهارا كما تعود. الآن لي الشرف أن أنا أقدم أستاذ الفاضل أستاذ الدكتور عاصم عبد اللطيف، أستاذ جراحة مخ وأعصاب جامعة عين شمس، فليتفضل.
Assalamu alaikum. First, I would like to thank Professor Dr. Sahar Hassanain and the organizing committee for inviting me to this prestigious meeting. It's really a very nice idea to have sort of a multidisciplinary approach for the assessment and management of one of the most common diseases with pediatric neurology and the pediatric neurosurgeons encounter. This is the pediatric hydrocephalus. It accounts or represents about 30% of the practice of pediatric neurosurgery, or I'm sorry, 30% of the practice of the whole neurosurgical operative load at Ain Shams University. And it's really very important to have a multifaceted understanding of the disease. A very smart idea to gather experts in the field of the pediatric neurology, the pediatric neuroimaging, and humbly myself to share ideas, to share perspectives, because honestly speaking, the practice at Ain Shams University and probably in the rest of Egypt is sort of dissociated, where each specialty are concerned and minded with their own perspective, and they're not sharing their ideas with colleagues. So we have conflicting ideas. Sometimes we argue, and I guess we will continue to argue for some time, but our gathering here helps to ameliorate the argument and also improve the sort of understanding and mutual benefit in favor for the patients. Hydrocephalus, to start with, I'm not talking about lecturing you about hydrocephalus, but just to give you an idea that even the definition of hydrocephalus was controversial, because we don't speak common language. You don't have the foundation for common understanding about which patient is considered hydrocephalus and which patient is considered ventriculomegaly. As Dr. Marwa has eloquently presented, patients with brain atrophy, hydrocephalus ex vacuo, these patients we argue about whether they need treatment or not, whether he is a symptomatic patient or not. But conventionally, or traditionally, we understand that hydrocephalus is a dilatation of the ventricular system with increase in the intraaxial CSF volume. And so we're concerned about the ICP, we're concerned about the etiology of the hydrocephalus and the anatomical topography, but sometimes we overlook the idea of the hydrocephalus ex vacuo and the brain atrophy, because in these cases, the dilatation of the ventricular system is on the expense of the brain mantle. So these patients we see often with post-irradiation, with post-infectious sequelae, they develop brain atrophy. Patients with repeated shunt malfunctions and obstruction, they develop brain atrophy, and sometimes they grow their ventricles, or their ventricles increase in size without having shunt obstruction. This is basically because there is a conflicting opinion about if this dilatation is due to the shunt malfunction or this dilatation is due to the brain atrophy and the subsequent ex vacuo dilatation. And here comes the MRI shuntogram that was presented earlier, that comes to differentiate these points if the shunt is functioning or not based on the imaging data. So to bypass this idea, another definition was proposed, which is the active distension of the ventricular system, which means that something is inflating it from inside, and this excludes the idea of the brain atrophy. But to give you an idea about how this has, even the definition of hydrocephalus has went through iterations and different reiterations, and even the pediatric neurosurgeons had to convene in a hydrocephalus International Hydrocephalus Workshop in Crete to come up with a definition to be endorsed by the International Society of Pediatric Neurosurgery, just to come up with something to serve the inclusion of external hydrocephalus into the definition of the hydrocephalus, because these patients with external hydrocephalus were overlooked. They were not treated for most of the time. They were, sometimes not considered as a subset of patients with hydrocephalus. So they included them in the definition in order to institute treatment for them. And one of the most common classic teaching paradigms is communicating versus obstructive. And this is a classic teaching as well. It also emphasizes the idea of the ventriculo-cisternal bulk flow, which means any obstruction to the bulk of the flow of CSF from the ventricular system to the cisternal space would definitely result in accumulation of CSF and subsequently an increase in the ventricular size and hydrocephalus. But this is emphasizing an issue of volume of the CSF. It's not, which is not a valid theory in some of the cases. We can see patients with post-irradiation sequelae, post-infectious sequelae who develop an increase in the ventricular size without an increase in the volume, actual increase in the volume of the CSF. So it could be related to an increase in the compliance of the ventricular system or a decrease in the elastic recoil of the surrounding brain tissue. And this is an issue, the pressure of CSF, which is to be emphasized in the future, or in the recent iterations of the classification of hydrocephalus, because it also relates to the systolic propulsion of blood into the cranial cavity with each cardiac cycle. And this is something that we are starting to take into account as a theory for the development of hydrocephalus in some patients. So it's no longer communicating versus obstructive, it's all obstructive. The question is, where is the site of the obstruction? And this is really important because it definitely relates to the proposed surgical management or the proposed treatment. We are starting to offer more endoscopic third ventriculostomy for patients with obstructive hydrocephalus. It's not all shunt for all patients anymore. And we're reserving the VP shunt for patients with obstruction or obstructive hydrocephalus, but outside of the ventricular system. Obstruction at the cisternal space, cisternal scarring with post-infectious hydro, or obstruction at the venous drainage or in the systemic circulation. And this is one of the diagnostic, the patients that we have diagnostic dilemmas or management dilemmas. This patient with external hydrocephalus may be asymptomatic, maybe incidentally diagnosed, or maybe presenting with simple forehead bossing and delay in the head support. Most of these patients will go without surgical intervention with conservative management, but some of them may require a shunt which we would be very discouraged to put, but at some point, the clinical situation dictates it. Why are we discouraged? Because the ventricular dilatation, as you can see, is not that appreciated. But if these patients continue to develop delayed milestones progressively or progressive forehead bulging with a divergent microcephaly, then we would definitely shunt them in a ventricular, in the form of a VP shunt. And these two patients, they're not the same. This is a hydrocephalus ex vacuo, as you can see, as you can all diagnose, with brain atrophy and brain mental loss, subsequent negative dilatation of the ventricular system. But in this patient, he has sort of ventriculomegaly, which is asymptomatic. Another more challenging case are these patients that we meet in their early adulthood and late adolescence. They have big heads, they have chronic hydrocephalus, which was asymptomatic, and if we do a fundus exam, then it's normal, because a slowly progressive increase in the intracranial pressure would not result in a papilledema. And then these patients present with manifestations of chronic hydrocephalus in the form of cognitive decline, unsteady gait, and incontinence. These patients, if they have, with the imaging proven obstructive hydrocephalus, they would do greatly with endoscopic third ventriculostomy, and there are many case reports in literature highlighting this treatment. So shunt would still remain the standard treatment for hydrocephalus for most of the patients, but I'm just highlighting the less famous options that we may use in specific situations. A ventricular access device, as the Ommai reservoir or ventricular subgaleal shunt, as we see here, is something that we use definitely, and there should be a first option to be offered for patients with prematurity, very low birth weight, and suffering from a progressive post-hemorrhagic ventricular dilatation. Why do we offer this? Because of the risk of the necrotizing enterocolitis, the shunt exposure, and the shunt infection. If we plant a shunt or a regular ventriculoperitoneal shunt in a patient with a body weight of 1.5 kilograms or very thin skin, we need to have a temporary CSF access device where we can do shunt taps, or we can do, taps and CSF drainage intermittently. And then until the patient is old enough or the weight permits 2.5 kilograms at least, or a very acceptable skin turgor, to plant a ventricular peritoneal shunt. And there's a large retrospective review. The colleagues at St. Louis University, Matt Smith specifically, they found that there's no difference between the Ommai reservoir or the ventricular subgaleal shunt. And even the fellows at Italy, Giuseppe Sinelli, he even went further and planted the Ommai reservoir or the ventricular subgaleal shunt in patients with progressive post-hemorrhagic hydrocephalus, and waiting until they require definitive treatment, then offering endoscopic third ventriculostomy. And he came up with very good results, about 60% shunt independence in patients who were traditionally shunt-dependent population. These are very encouraging results. So we can do more endoscopic third ventriculostomy in patients with apparently communicating hydrocephalus or non-obstructive hydrocephalus. Recently, what is gaining popularity in our institution at Anchamps is the endoscopic ventricular lavage. It was introduced by Willie Mutlow at first in a multi-center RCT with 70 patients recruited for the drainage fibrinolytic therapy for progressive post-hemorrhagic hydrocephalus or progressive dilatation, progressive ventricular dilatation in a post-hemorrhagic sequelae. The first results, or the early results, were fairly the same, comparing the DRIFT trial to the standard treatment, which is repeated lumbar puncture or medical treatment. When they analyzed shunt dependence or death, they found that there was no significant difference. But really, on the long-term follow-up, they did elaborative work and finding very encouraging results about the improvement of the cognitive disability in these patients with who undergone the endoscopic lavage or the ventricular lavage. 66% of them, they had no cognitive disability, compared to the 35% in patients with the standard treatment who didn't receive the lavage. And so the DRIFT trial is the first intervention for the progressive post-hemorrhagic ventricular dilatation to objectively demonstrate sustained cognitive improvement. In this sense, doing more endoscopic lavage for patients with post-hemorrhagic hydrocephalus is really an important option to offer for these patients. Endoscopic third ventriculostomy, or ETV, is having growing popularity recently, and we really assess the likelihood or the suitability of the patients for ETV using this ETV success score offered by a landmark paper. The score, as we can see, takes into account the variables as the age, etiology, and the presence of previous shunt. With the lowest score in the very young age, we cannot offer ETV competently for patients younger than 1 month with post-infectious hydrocephalus or had previous shunt, because the likelihood of success was close to 0, as you can see. But we are confident in offering ETV for patients who are older than 6 months with aqueduct stenosis or obstructive hydrocephalus, intraventricular obstructive hydrocephalus, and no previous shunt. Their likelihood of success is around 50 to 60% or even 70%. Doing the ETV, just as a quick thing, we do the endoscopy or the endoscopic approach through a frontal burr hole and go through the brain into the ventricles. And that's a patient with hydrocephalus. I want to show you inside. Yeah, that's the trajectory. That's the trajectory that we use for the endoscopic entry through the frontal horn. And then it gives us an access inside the ventricular system. That's the floor of the third ventricle, as we can see through the foramen of Monroe. We puncture the floor of the third ventricle and then widen the puncture using the Fogarty balloon catheter. Any membranes, as the Lilliquist membrane in the prepontine cistern that we can visualize, should be dissected completely to ensure a functioning endoscopic third ventriculostomy using combined action. So currently at the neurosurgery department at Ancient University, we have two clinical studies going on. One of them is on the efficacy of the endoscopic lavage. We extrapolated the DRIFT trial to the use of the endoscopic lavage for post-infectious and the CSF infection. That's one thing. The other one is the implementation of a certain protocol for the management of the of hydrocephalus in infantile period using the endoscopic third ventriculostomy combined with a choroid plexus cauterization, because this is claimed to increase the success of the ETV by adding about 20 to 30% of success using the or attributed to the cauterization of the choroid plexus. Why did we do this? Because, as Professor Dr. Sahar said earlier, that we found that the most common etiologies that we are dealing with are the Chiari type 2 associated hydrocephalus and the post-infectious hydrocephalus. I will go quickly, skim quickly through the study. We want to show, yes, here. We placed the patient on the side and we planned the flexible scope. That's a scope that's around 3.5 millimeter in the 2.8 millimeters in diameter. And it goes inside this small skin opening and burr hole. The view is, I guess it's good and acceptable. We can go inside the ventricular system. The view, as you can see from the video, is the optics are less optimal or less clear than the compared to the solid lens as in the video that I previously showed. We can go very deep down to the prepontine cistern using the flexible scope because of the soft turgor and the small size of, or the small diameter of the scope itself. We can go in front of the basilar artery to see the dorsum celli, to even go close to the CP angle cistern and close to the foramen magnum to see the lower cranial nerves. So the ETV CPC, currently we have recruited around 50 patients. Success rates are ranging from 60 to 70%. Failure, in cases of failure of ETV, we can do another trial of a redo ETV. And that's really, to me, is a surprising change of concept, because early on, about 15 years ago, when we mentioned the use of ETV or endoscopic lavage, this concept was, or this thought was strongly discouraged because of the lack of advanced equipment, the suboptimal optics, and subsequently the high risk profile of the procedure in the early experience. But recently we are getting somewhere in terms of reviving few techniques, not introducing new techniques, but reviving techniques that fell out of favor with time. Thank you.
Thank you, sir, for this elegant presentation. Really, I learned from you, Dr. Azam, and I'm going to change my education policy for the undergraduates regarding hydrocephalus. Okay. Now, to finish with this common problem with, is it preventable or not? Can we prevent hydrocephalus? I think neural tube defects in the maternity hospital, the mother should receive 400 milligrams of folic acid 4 weeks before conception, at least, and for 8 weeks after conception to prevent neural tube defect, especially if she has a history of neural tube defects. Post-meningitic hydrocephalus, Dr. Ahmed Mahdi. You are the source of post-infectious hydrocephalus. He's working in the fever hospital. Infants. And the post-neonatal month,
Yes.
we have the same problem. The fever, disturbed conscious, convulsion, and missing that this could be meningitis and treated partially with oral antibiotics. We later on, after 2 or 3 months, we have progressive enlargement of the head.
As they have the meningitis of hospital-acquired infection like Klebsiella, E. coli, Acinetobacter, not the common like pneumococcal or meningococcal.
Okay.
So
we have the sources, NICU
Yes.
and the fever hospital. we have to revise early diagnosis and management, the vaccination schedule for the infants. Post-hemorrhagic hydrocephalus, as Dr. Asim said, we can prevent it by good antenatal care, good birth care, prevention of prematurity, please in the NICU and in the post-neonatal age, following up the occipitofrontal circumference, not for growth. It will be for the progressive enlargement. In a week, 2 centimeters, I think you have to refer to the neurosurgeon, please. Professor Asim revised all the management of post-hemorrhagic hydrocephalus in premature babies less than 34 weeks of gestation. Now, the obstetrician has a role to prevent, the neonatologist has a role to prevent, pediatricians following the development and occipitofrontal circumference, please, and management of hydrocephalus will be a share between us, pediatric neurology with the pediatric neurosurgery, with the daily quarrels we have, who will get rid of the patient. Gross curves, we have to follow our guidelines of care in patients with shunt or hydrocephalus. Thanks to Dr. Asim, the NeuroKids initiative. This is the first time we have a registry to know where we are. At the same time, they are educating regarding the endoscopic third ventriculostomy and choroid plexus cauterization. I think we have to educate all over Egypt. I think they are doing that. It is an educational, international initiative. And thank you.
شكرا جزيلا استاذنا الفاضله الاستاذ الدكتوره سحر حسنين. دلوقتي خلاص احنا هنقفل السيشن ده. حد عنده اي اسئله؟ دكتوره هدى اتفضلي.
حياتك ايه بس do you think that neurosurgeons on the whole interfere at an appropriate time for hydrocephalus, or they usually delay the interference to the patient clearly progresses? And I'll take my clue from the patient Hagar presented, because as you could see that once the shunt was applied, even before the chemotherapy, she improved. So are we a bit, should we change our management for hydrocephalus?
Okay, thank you, Dr. Hoda, for this nice question. And it's really a critical question because the answer would have some political implications. Most of the neurosurgeons, لا مفيش مشكلة خالص. يعني I was involved directly in the patient, and I was really the one responsible for delaying the intervention. At first, we thought he has shunt infection, so we need to get rid of the shunt. And so we removed the shunt and see if he would become shunt independent later on. And for some time, he deceived us, and we thought that he is shunt independent. Some acceptable permissive ventriculomegaly is seen on the MRI, but he wasn't manifesting at that point. Apparently, the changes in the MRI predated the clinical deterioration. And so when he deteriorated, we thought that this could be related to the infection because it's a confounding variable. And with all honesty, we delayed the intervention, but based on the CSF opening pressure. We did 2 types. Yes, the pressure was normal for 2 times. We did opening pressure. It was normal for his age. It was 6, then 10. But then when we did the CSF opening pressure, when we definitely took the decision to put in a shunt, it was 25. So this is a learning patient. This is a patient where we learned from him a lot, and we could definitely revise the indication for planting a shunt or the timing of the intervention. Definitely a patient with progressive ventriculomegaly coupled with clinical deterioration, he needs intervention without justifying or trying to escape the intervention by measuring the CSF pressure, because sometimes the CSF pressure would objectively is the answer to the question, but in this patient it deceived us. I don't want to be the silly person to generalize based on one patient. We need to have few other patients similar to this in order to come up with a valid recommendation, but definitely progressive ventriculomegaly predates the clinical deterioration. And for this particular patient, the clinical deterioration was thought to be related to the infection, but apparently it wasn't.
شكرا. دكتور شورى عنده تعليق، اتفضل.
الأول في أي أسئلة تانية؟ الحقيقة أنا هعمل يعني 2 or 3 comments الحقيقة يعني 1 point for the clinical diagnosis and 1 point for the investigation. في النيونيتس الحقيقة ما بنشوفش البابيليديما، لكن بنشوف الماكروكيفلي مع البالجينج فونتانيل. ما بنشوفش الفومتنج ولا الهيديك في النيونيت. لو بعد كده شوية يبقى انفانت أو ايرلي تشايلد هود ممكن يبقى عندي هيديك، فومتنج، disturbed level، ممكن ما لقاش بابيليديما لو هي الهيدروكيفالس كرونيك، لكن لو في اكيوت هيدروكيفالس اشوف البابيليديما موجوده عندي. بالنسبه للدياجنوزيس الام ار اي الفائده بتاعته الحقيقه في حاجه اسمها دكتور خالد يقول لي بقى اللي هو فيتال ام ار اي، يعني ممكن اعمل ام ار اي with the fetus inside the hope of the mother لو انا عارف ان في congenital هيدروكيفالس بيحصل او في ديفورميتي او حاجه، ففيتال ام ار اي ممكن ونو هازاردز الكلام ده كده. الحقيقه التريتمنت هو البريفنشن. وانس حصل الهيدروكيفالس هيحصل كومبليكيشن وشنت اوبستراكشن وشغلانه. احيانا في زي ما اتقال زميل ان دكتور عاصم ان لازم افرق بين البرين اتروفي والهيدروكيفالس. يجي لي كتير قوي يقول لي ايه ده هيدروكيفالس، ابص ان في اتروفي موجود، ده سمول برين وده برين اتروفي مش هيدروكيفالس. وساعات نقول مثلا في هيدروكيفالس فالنيوروسيرجن يقول لي يعمل سي اس اف فلومتري، فيقول لي دوت يعني استابليش هيدروكيفالس ولا بروجريسيف ولا ريجريسيف. فدي الدياجنوزيس مهم قوي، وتريتمنت البريفنشن اهم حاجه. جاي اسئله؟
قبل حد عنده اي سؤال تاني؟ قبل ما نقفل الجلسه دي بس بعد اذنكم انا ليا صديق فاضل الدكتور سمير منير، هو أستاذ بيدياتريك نيورولوجي في جامعة المنيا. هو جاي المؤتمر من المنيا، أحد عباقرة الصعيد في بيدياتريك نيورولوجي. فبكلمه قبل الجلسة: اتأخرت ليه؟ هو أنت ناوي تعتذر ولا إيه؟ فقال لي الجملة الجميلة بتاعته: وهل أطيق غيابا أيها الرجل؟ فده والدكتور عاصم بيه بيقول المحاضرة بتاعته وأنا عمال أنظم في الوزن والقافية وبظبط، فجتني خاطرة قصيدة العصماء للأعشى ابن قيس، اللي هي بيقول فيها: ودع هريرة إن الركب مرتحل، وهل تضيق وداعا أيها الرجل؟ فنظمت على غرارها هذه القصيدة، وهذا في الشعر مقبول به ومسموح به، إذ أن أعظم شعراء العربية أمير الشعراء أحمد شوقي نظم قصيدته العصماء نهج البردة على قصيدة الإمام البصيري اللي هي البردة. فنظمت الآن وأنا بعد محاضرة الدكتور عاصم وأثناءها قصيدة على غرار قصيدة الأعشى بن قيس، فقلت فيها: يا سمير ودع الدمرداش إن الركب مرتحل، وهل تطيق غيابا أيها الرجل؟ محاضراتها غراء فرعاء مسقول عوارضها، تمشي الهوينة كما يمشي الوجى الوعل، كأن مؤتمرها بين جاراتها مر السحابة لا ريث ولا عجل، تسمع للعلم والعلماء وسواسا إذا انطلقت، كما استعان بريح عشرق زجل. قالت الدمرداش لما جئت زائرها: مرحى عليك ومرحى بمن رجل. شكرا جزيلا.
انا مش قادر، انا اقعد اتفرج، انا عاوز اتفرج، انا لا ما بحبش، لا والله. نبدأ بقى يجي.